Good afternoon. My name is William Hope, and I am the Physician Access Coordinator for the North and West regions of Allegheny Health Network. On behalf of myself and my colleague Megan Graham, we would like to welcome and thank all of you who were able to join us this afternoon. This webinar is being recorded and will be published at a later date and time for anyone who was unable to attend. All participant lines are muted. If you have any general questions during the presentation, please use the Q&A function found on the bottom of your Zoom toolbar, and we will do our best to address them during or at the end of the presentation. Practice-specific questions will not be addressed during the presentation, but we will work to provide answers following today's meeting. And now it is my pleasure to introduce today's presenter, Dr. Stephen Bailey, the Chair of Allegheny Health Network's Cardiovascular Institute and the System Chair of the Department of Thoracic and Cardiovascular Surgery. Dr. Bailey.
Thanks, William, and thanks everybody for joining us today. It's really my pleasure to talk to you about the Cardiovascular Institute, and I appreciate you're taking time out of your busy days to hear about it. By way of introduction, again, my name's Steve Bailey. I've been with Allegheny Health Network for about 15 years, which is hard for me to believe at times because I still feel like I'm the new young guy. But in any case, I'm clinically a heart surgeon that's done most of my clinical work at Allegheny General Hospital over the years. Earlier this year, at the start of the year, took on additional responsibilities leading the Cardiovascular Institute, which we'll obviously spend a lot of time talking about. A couple of ground rules for today. I'm going to shoot to keep this to 45 minutes, both because of some clinical responsibilities on my end here, and also I think it would be somewhat painful to hear me droning on for more than 45 minutes about any topic, even one such as great as the Cardiovascular Institute. And then finally, I know because of technical limitations, there's no video and no vocal interaction. I think it would be much more helpful and interesting if you have any questions about what I have to say or what I'm not saying or anything about the Cardiovascular Institute. I would love to focus the conversation on specific areas of interest or concern or opportunity that you have. So please feel free to use the chat function. And again, I would be thrilled if I'm interrupted as I go through the slides. With that, we will get started. So we do have a mix of, a variety of different types of people on the call today, both, employees and members of Allegheny Health Network, as well as aligned physicians and staff. And so just a couple of slides about who we are and what we do. AHN obviously was founded long after I started at Allegheny General and West Penn Allegheny Health System in 2013. We serve Western Pennsylvania, Ohio, and West Virginia, and we have a large footprint with more than 21,000 employees. We're very much a blended health organization with our parent company, Highmark Health, working to really dramatically and in a revolutionary way change how healthcare is provided and how health is achieved. We have, as I mentioned, a large footprint, including 9 hospitals with the 9th or 10th opening today, as a matter of fact, Wexford Hospital, north of the city, 7 surgery centers, 5 health and wellness pavilions, and 4 neighborhood hospitals. It's a huge priority for Allegheny Health Network and Highmark Health to push the highest quality care closer to our patients in the community. Evidence of this huge commitment is seen in the 4 neighborhood hospitals that have been built over the last several years that have been particularly helpful in the really trying times of the last 2 years during the COVID pandemic. As I mentioned earlier, just at 9 a.m. today, Wexford Hospital opened to the public and open for care. Again, not a moment too soon, as we at Allegheny Health Network and really every facility in the region is struggling with full hospitals, shortages of staff of all kinds. So we are really welcome the addition of AHN Wexford to our family. I mentioned, we're investing not just in new hospitals, but in our existing hospitals. I won't go through point by point, but hundreds of millions of dollars in investment in the Cancer Institute, improvements across our network at St. Vincent's, Jefferson, West Penn, Forbes, and Allegheny General Hospital just in the past couple of years. our operational model is very much physician driven through the mechanism of our institutes, the Cardiovascular Institute being one of them. And every single day I'm thinking about and working with my colleagues trying to figure out how we can raise the bar in advanced care through innovation and new techniques and technologies, mostly here at Allegheny General Hospital, as well as actively and aggressively pushing recently developed technologies and techniques into the community in partnership with our integrated network and our community colleagues to bring the latest and greatest care into the community with some really concrete examples of that just in the past couple of months, which we'll talk about. So getting to the Cardiovascular Institute. Again, I'm super proud of the Institute. I mentioned I took over the leadership of the Institute earlier this year after about a year-long search process. I wasn't at a stage in my career where I was really actively looking to take on a system department or institute leadership role. I wasn't looking at other places, but after giving a lot of careful thought, I was really committed to trying to lead this institute, this network, because of my experience here, because of really mostly the phenomenal people that I've had the chance to work with over the past 15 years. I felt like, in the year 2021, that I was a good, and in my mind, the best candidate to lead the institute, and so I'm thrilled to have been offered that opportunity. The CVI extends again over a broad geographic footprint. While up until a couple of years ago, I was personally mostly focused on the north side at Allegheny General. Took over system leadership of cardiac surgery several years ago, and that was great process for me. Working directly with colleagues at all of our different campuses and really learning from best practices there. We'll get to it soon, but there's a tremendous amount of benefit to us working together with a two-way flow of information. This is just a snapshot of some of the phenomenal physicians that I have a chance to work with. And really the theme that runs throughout the surgical and the medical sides of the CVI is essentially every single program is multidisciplinary in nature, collaborative, thoughtful, innovative, and really above all else caring. We care for each other in terms of our physician colleagues and our staff, as well as, of course, for our patients. And the patients and our own team is really at the forefront of everything that we do. The Cardiovascular Institute is organized in this way with a Department of Cardiovascular Medicine led by my longtime colleague, Srinivas Murali, and the Department of Thoracic and Cardiovascular Surgery. So as I mentioned, we're extremely collaborative. We're really trying to push the boundaries of care in a meaningful way with funded research. And this has helped develop a tremendous number of really niche programs that serve really every aspect of the community with regards to rare and difficult to treat diseases. And again, we'll get into that shortly. So one pet peeve of mine is the concept of a hub and spoke system. I'm sure many of you have heard that idea. My vision and my goal for the CVI at AHN is the polar opposite of that, or rather a very coordinated cardiovascular system with multiple interdependent parts. Of course, we're not going to do every single thing at every location. And you can see, at different hospitals and different sites, we'll have varying levels of service, but those, each site will work, independentely, but collaboratively with every other part of the system. And each part makes the rest of the system whole and more effective. We made tremendous amount of progress in terms of, the teams that are practicing primarily at each of these hospitals, working, on the ground in the same room with other physicians from other hospitals. And it's been a really, really fantastic process and has allowed us to extend, novel techniques and technologies and procedures, broadly into the community. We've gone over the past 15 years in the cardiovascular space from working in silos where, cardiac surgeons were competing for patients with interventional cardiologists and electrophysiologists. And that paradigm has completely flipped on its head. such that every single thing that we take care of, from heart failure to valvular heart disease to coronary artery disease to thoracic aneurysms and multiple, more medically focused areas, are completely team-based, multidisciplinary, where we rely on a breadth of extremely well-trained and highly specialized physicians and staff to come together for the best possible treatment plan and path forward for every individual patient. The Cardiovascular Institute has a tremendous number of specialized programs that I won't run through specifically here, but we'll touch on many of them. And again, against this backdrop is a tremendous breadth of clinical trials, over 100 active clinical trials, investigating and developing and innovating, the newest, pharmacologic therapies, surgical and interventional therapies for our patients. It's really an incredibly exciting and dynamic time to be a caregiver in the cardiovascular space. So many of you, perhaps more of the AHN employed members on the line here, have heard a lot about this living health, which really is truly a new and revolutionary attempt to change health and healthcare. And the general idea is that we're working with AHN and Highmark and a bunch of ancillary support, some outside experts from Verily, and some huge analytic and data support from the Google Cloud, to really try and push the incidence of care way upstream, so that we're taking care of problems instead of with a procedure, 3 or 4 or 5 years down the road, intervening before clinical problems get too large. Obviously, a tremendous amount of effort and work is being done in this, and we are very confident that as we at AHN and are working with leaders in the field from Google and Verily and our other partners under the Highmark Health umbrella, we have the potential to really completely fundamentally change how healthcare is provided and how health is maintained. So in doing this, we're working towards the quadruple aim, which is quality outcomes, affordable care, improved clinician and staff experience, and improved customer experience. Again, multi-year revolutionary process, which we're just starting. So now I'm going to dive deeply into all the different nooks and crannies of the Cardiovascular Institute, but I thought maybe I would pause here to see William or Megan, if anybody has chimed in with any questions.
Nothing so far.
All right, a guy can hope. So I thought, after talking about living health and moving care upstream, a great place to start is our disease prevention programs in the Cardiovascular Institute. These are focused in the Department of Cardiovascular Medicine, but again, multidisciplinary in nature. So we have 2 hospitals, AGH and West Penn, which are both AHA certified comprehensive hypertension centers with just fantastic multidisciplinary, super specialized care provided in the leadership of Dr. Tadakamala Purnima and Khalid Nasher from the nephrology team. Again, everything from just sort of garden variety, hard to treat hypertension to 4-drug, completely malignant hypertension, and everything in between. A really tremendous resource for the patients of Western Pennsylvania. A theme that I will be, perhaps reiterating ad nauseum as we go forward here. In similar fashion, we have dedicated Lipid Clinic throughout the AHN Cardiovascular Institute. This again, another common theme. Some of the same actors with diverse interests and really a tremendous passion for these programs. Indu Purnima and Raghu Tadakamala. Working through, from garden variety hyperlipidemia to familial hyperlipidemia, drug-resistant hyperlipidemias, and everything in between. Again, to the extent to which this effort is successful, I would be thrilled to have many fewer, particularly many fewer per population density patients who need coronary bypass and other end-stage cardiovascular interventions. So we have a tremendous focus on women's heart and women's heart health. you hear this in a lot of different ways, but cardiovascular medicine and treatments and therapies is not homogenous and is not the same for men and women or even children. And we have a phenomenal team that is really dedicated to gender specific assessment, risk management, diagnosis, and management. Again, led by a phenomenal trio of women clinical cardiologists, each of whom has an additional area outside of general cardiology that they focus their interests on. But Val, Anita, and Indu are just a phenomenal team, phenomenal resource, and we're actively adding to this team as well to be able to broaden our scope. So Cardio-Oncology, another sort of newer program, but really important. So we've got a huge new commitment and effort to the oncology space, which I'm sure all of you have heard about with regards to the academic cancer center here at Allegheny General Hospital and new cancer centers throughout the region. So cancer, and particularly cancer treatment, is really important to keep an eye on with regards to cardiovascular health. The life-saving cancer therapies can and often do have secondary effects on the heart that ideally can be prevented or modified and or ultimately treated with one therapy or another. So we're actively involved in the cardiovascular care of cancer patients from essentially from the time of their diagnosis of cancer and their treatment plan to well after their cancer therapy is completed, as the effects of cancer therapy on the heart can be delayed for many years after the treatment is done. Again, the same trio of fantastic cardiologists with the addition of Rachel Hughes here in Pittsburgh, and then just launched a formal cardio-oncology program and clinic in Erie with Orestes Pappas and Jasmine Castellanos, another fantastic part of our team in Erie. So we'll pivot to heart failure, and I've been begging for 15 years in my partnership with Srinivas Murali and the rest of the heart failure cardiologists that they really have a branding problem, right? Like, who really wants to go to a heart failure clinic? But despite my complaints to find a better theme for the concept of heart failure, such as like heart recovery or something on those lines, we still call it heart failure. But I digress. So again, really common theme that this is really in the cardiovascular space, the program that really led the multidisciplinary approach to care. So we have cardiac surgeons, interventional cardiologists, general cardiology, advanced heart failure physicians, all working together to come up with the coordinated plan for patients with this really highly mortal problem. There's a tremendous number of new therapies, new drugs, new interventions that can help stop and often reverse the process of heart failure. And I can't stress enough, for your patients with heart failure, with a touch of heart failure, with a little bit of a low ejection fraction, with heart failure with preserved ejection fraction, how impactful being seen by a dedicated team who all they do all day, every day is think about heart failure can have on the quality and quantity of life of your patients. I'm obviously biased, so my clinical background, from the get-go was involved in heart transplant and left ventricular assist device therapy. But I'm never ceased to be amazed by the impact and the quality of this program and the impact that it can have on our patients and their families and their lives. And this program is not just centered here in the city. Have outreach programs extending really throughout the entirety of the AHN footprint and beyond. So the heart failure program, again, extends throughout our footprint and has been recognized in numerous ways by various certifications and recognition programs. And again, don't have the bandwidth or the time to go through all of these therapies, but just know that unless you specifically are a heart failure physician, it's just impossible to keep up on the latest in terms of drug therapy. Like just in the last couple of weeks, phenomenal data coming out about some of these diabetic medications that have salutary effects on heart failure, as well as more complex interventional therapies. So love to see your patients and super confident that we can add value to their care. So one branch of the heart failure program is the pulmonary hypertension program. This focuses on pulmonary arterial hypertension and the 5 classes of pulmonary hypertension. Again, it's the same group of physicians with a sub-selection of them that have a special expertise and passion for pulmonary hypertension. Again, I think an area of really differentiated care and benefit to your patients by being seen by people who really think about this like all day, every day. AHN CVI has a relatively new amyloid program. This has been generated renewed interest and excitement, largely because of the increased recognition of amyloid, and more importantly, because there's actually ways to treat amyloid these days. So several new drug therapies that can halt and reverse amyloid again, and really impactfully change our patients' lives. This program is under the leadership of Craig Alpert, who wears like 19 different hats, just an amazing human and a good friend, and one who will take phenomenal care of your patients. The imaging program at the AHN CVI is absolutely world-class. Again, harping on the same thing, but really a differentiated product in a number of various areas. Cardiac MRI, led by Bob Biederman, is one of those areas. Bob is a world-renowned cardiac MRI specialist. He's one of the few labs in the country that does cardiac MRI in patients with pacemaker implants and other devices, and does it safely, which is often just hugely important for determining direction of therapy, and who otherwise wouldn't be able to have that study. I won't get into the details, but again, MRI provides phenomenal imaging for a variety of different myocardial problems, Bob would argue it's the single best test for virtually everything in CV. I wouldn't go that far, but it really is, the technology and importantly, the expert interpretation, is supremely valuable. It's very helpful in amyloidosis and in myopericarditis, such as in the, seen in recent, COVID-19 era. It's pretty darn good for looking at valvular problems. I wouldn't necessarily say it supplants transesophageal echo for mitral valve in particular, but gives really, really great, high quality, high definition images. Here we see some mitral valve pathology and mitral regurgitation and various forms of aortic valve anatomy. So the cardiac MRI program is expanding again widely throughout the network, and is extremely well regarded and well published, with recent publications up to and including the New England Journal of Medicine. Our team, again, led by Bob Biederman and supported by Victor Farah, Manil Shah, and Anita Radhakrishnan, as well as Jay Badlani, who was just recruited and is full-time at our Forbes campus, where we have an additional MRI magnet. So Echo Lab is again fantastic. It's been leader since the beginning with the lab named after Claude Joyner as a world-renowned echo imager back in the early days. Basically Echo is present at all of our physical locations, and I think as a cardiac surgeon who relies deeply on the quality of the imaging and the interpretation, I think there's tremendous value in the ability to avoid repeat testing by when echoes are performed within our constructs. Having said that, I personally and we as a group work really hard to not needlessly repeat images, and so if images from outside offices and clinics provide the necessary information, we're more than happy to work with those images for sure. Echo Lab is led by Rachel Hughes-Deutschev, and again, of the absolute highest quality. I participated in a number of national, international research trials. Our echo is graded routinely and compared to other centers by core labs, and routinely we're in the top 2-3% of performing sites, and couldn't be more proud of our program and its leadership. Cardiac CT is another, newer and super valuable imaging modality. Working hard to make this non-invasive modality be able to supplant invasive cardiac catheterization in many settings to avoid risk and cost associated with that. Sorry, I'm pausing because I actually got a question, which is fantastic. And the question was, is there a specific contact person for patients that may benefit or be interested in a cardiac amyloidosis support group? So that's a fantastic question, and I'm going to defer answering because I don't know the answer right off the top of my head, but I will for sure bet that William can take your contact information, Leslie, and I'll connect you with Craig in the program, because yes, I'm sure that we have some support. So thank you. As I was saying, yeah, cardiac CT is any place that we're putting a new program, we're adding cardiac CT because of its tremendous ability to look at the coronary artery anatomy, look at coronary artery flow, and avoid unnecessary invasive cardiac catheterization whenever possible. This program is led by Monil Shah, who's also well published in using this newer technology to minimize the need for unnecessary catheterization. We have the only cardiac PET program in the region. Only one. Take referrals from every hospital in the region, including UPMC, because of the quality of the program. PET is the test of choice for myocardial viability across a broad spectrum, but particularly helpful for a couple of specific areas: post-cardiac transplantation, and the diagnosis and prognosis of cardiac sarcoidosis, and it's super helpful, super valuable. Our PET program is led again by our a wide breadth of our clinical and imaging cardiologists on the leadership of again Indu Purnima. Again, I feel like I'm just sitting up here bragging, but our EP team is second to none anywhere across the nation. Led by Amit Tassani, provide absolutely the highest quality, innovative care, and again, do it through a multidisciplinary approach, in this case to atrial fibrillation, getting all stakeholders involved, following network-wide pathways and a standardized protocol-based care for best outcomes. This program is one of the leaders in the nation, and really first in the nation to use zero fluoroscopy procedures to provide safe and effective AF ablation without exposing patients or their caregivers, their team, to ionizing radiation, as well as novel, newer energy sources for actually conducting the ablation. And the vast majority of these patients can have these really highly complex procedures and be discharged on the same day. We rely on really high-tech imaging patterns to test the efficacy of our ablations during the procedure to minimize the need for reinterventions, and currently performing between 500 and 600 AF ablations across the network annually. There are a number of additional interventional therapies in the EP realm, from left atrial appendage occlusion to minimize the risk of stroke in patients who are intolerant to Coumadin. We have a dedicated atrial fibrillation research program funded by the generosity of the Mario Lemieux Foundation, and working in collaboration with phenomenal researchers from Carnegie Mellon and throughout the region. Have a special interest and expertise in the life-threatening and really often really hard to treat ventricular tachycardia. George Shaw and Amit Tassani take the lead here. Both coming from the best training programs in the country, and attracted to come here to AHN because of the phenomenal group that they're able to join and the best-in-class care that's being provided. So we'll pivot now to the Department of Thoracic and Cardiovascular Surgery, a little closer to my sweet spot. And again, just we sort of artificially divided the topics between medicine and surgery. Again, my comment about really everything we do being multidisciplinary could not be any more true when talking about the Department of Thoracic and Cardiovascular Surgery. So coronary artery disease, obviously the first topic we talked about was disease prevention. So every surgeon on here would be more than happy to have fewer coronary artery bypass grafts to do, and our interventional cardiologists would be more than happy to have less need for stenting and other interventional procedures. But to the extent that it's needed, this team is best in class. Just the last 2 cycles of the STS, which is the Society of Thoracic Surgeons, which all programs in the country report to. Cardiac surgery has had public reporting of our outcomes for really longer than any other field since the 1980s, and rated on 1, 2, and 3-star scale. And the AHN program is rated 3 stars for the last 2 cycles, and that represents the top 7 or 8% of programs in the country, in any given cycle. So something that we're super proud about, and feel like another area where your patients get importantly differentiated care by being seen and cared for at AHN. So we got a really highly developed aortic valve program, one of the first in the region to perform transcatheter aortic valve, and have performed 2,000 cases, more than 2,000 cases in the 9 years that the program has been open. We've been active in training physicians from around the region that have led to programs starting at St. Clair, Washington, Beaver, Jefferson, and recently Jefferson and Forbes Hospital within our network. We're pushing the boundaries of transcatheter aortic valve with novel access routes, advanced procedures where just straightforward transcatheter valve is not appropriate or safe, and have been involved in the most important clinical trials that have led to the acceptance of the therapy over the last 10 years, and the most important trials going forward, looking at therapy expansion and making sure that we're intervening at the right time, not too early, not too late. So, just outline the TAVR team here at AGH. The TAVR program has been active at St. Vincent's and Erie since about 2013, if I remember correctly. And again, not to toot our horn too much, but in the most recent cycle, also received STS a 3-star rating for the TAVR program and for a surgery program for aortic valve replacement with CABG. Again, probably 2 or 3% of programs in the country have 3 programs or 3 procedures falling into that 3-star realm. As proud as I am of the aortic valve program, which I'm sort of intimately involved in, perhaps even more proud of the mitral valve program. This is led by my colleague and the division director for cardiac surgery for the network, Walter McGregor. This encompasses everything from standard open mitral valve repair and replacement to robotic mitral valve repair, which is the majority of patients with degenerative mitral disease have, to novel therapies like percutaneous mitral valve replacement and transcatheter edge-to-edge mitral repair with the MitraClip or Pascal device. Again, this program is very multidisciplinary and multi-institutional. We see it as important that whether your patient enters in the north in St. Vincent's and east at Forbes, that they're going to be considered by our multidisciplinary group as an individual for the best possible therapy for them. Again, Walt McGregor spent the last 10 years perfecting mitral valve repair using the assistance of the Da Vinci robot. Again, the only program in Pittsburgh, and Wally is without question a world-class mitral valve repair surgeon. I send all my patients and would send my family and friends to him. Does a phenomenal job, leading the team and conducting the surgery. So. In addition to being the only robotic surgery center in Western PA, again, just in this last cycle, we received a 3-star award for mitral valve, in addition to the 3 other programs. Again, just a tiny minority of programs have this breadth of expertise and phenomenal outcomes. And we're in the process of really actively extending the minimally invasive mitral presence to Erie, under the direction of Tom Person. In addition to the 3-star commendation, the mitral program was just recognized by the American Heart Association and the Mitral Foundation as a mitral valve repair reference center of excellence. It was the 12th program in the country to receive this recommendation, and again, the only one in Western Pennsylvania. I guess, the theme I'm driving at here is I think it really matters, particularly for some of these, lower volume niche programs. It really matters, being seen and cared for by the right person and the right people. CTEPH is chronic thromboembolic pulmonary hypertension. This is when patients have high pulmonary artery hypertension secondary to blood clots. Our CTEPH program yields results like these. Sorry if it grosses some people out, but these are chronic clots evacuated from the pulmonary arteries by our fantastic most recent partner, Candace Lee, who trained with us here at Allegheny and then went out to the world's leading CTEPH program at UC San Diego, and we were able to recruit her back. She works in partnership with Manri Kanwar, who's the clinical lead on the medical side, and Mithan Chakravarthi, who's the interventional lead, supported by a tremendous team. For better or for worse, there's a tremendous amount of cardiogenic shock out there. We've learned over the past several years that by approaching cardiogenic shock with a team-based multidisciplinary approach, we can really impact outcomes. Our team is led, interestingly, perhaps from your perspective, by a heart failure doc, Manri Kanwar. She is deeply involved in the most important research efforts around the country. Has published over 20 patients this year, mostly in this realm of cardiogenic shock, in collaboration with Tufts and Harvard and Cleveland Clinic, Mayo Clinic, and is joined in the program by my colleague Masaki Tsukishita, who also leads our transplant LVAD program. And again, these protocolized pathways in terms of rapidity of care, guideline-based care is leading to a dramatic improvement in this highly mortal condition. We have lots of tools in our tool shed, and in terms of taking care of these patients, we, in the last, couple of months, launched a shock pager so that if anybody is in shock anywhere throughout the system, the core team is called, and clinical data can be shared, and the correct treatment pathway can be initiated. Again, we expect to see ongoing improved results for this really, really dangerous condition. One of the tools in the tool shed is ECMO, or extracorporeal membrane oxygenation. This can either provide total lung support for patients with lung failure, brought on by ARDS or sometimes the flu, more recently by COVID-19, or complete cardiopulmonary support for patients who need support of their heart and lungs. The general principle of ECMO is that as soon as we have patients on ECMO, we're trying to get them off to something either less invasive or less morbid. For VV ECMO, we can have people on support for upwards of a month or two, and particularly in the flu, can see dramatic recovery after that period of time. Again, we have a dedicated ECMO team and a multidisciplinary team supporting the core leadership, leading to highly coordinated and effective care. Received the ELSO Center of Excellence Award in 2015, 18, and 21, and we've transitioned the leadership from the cardiac surgery division to our critical care division by the absolutely phenomenal and passionate care of Mike Collins and Subaru Eleva-Paloru. Left ventricular assist device therapy is another therapy for end-stage heart failure. Patients who aren't a candidate for heart transplantation, either immediately or in the immediate future, can be completely supported with regards to their left heart function with an implantable LVAD. Again, we've been involved in the most important clinical trials leading to better and better technology, artificial heart or left ventricular assist device, I think, is sometimes associated with a highly mortal and morbid operation and care pathway. But our most recent look at 1 year survival, we had a 96% 1 year survival for this really sick patient population. And this is particularly impressive when we're only implanting LVADs in patients who have an expected 1 year mortality in the 40, 50, 60% rate. So dramatically improving quality and quantity of life with this therapy. the LVAD team at AGH, and this is centered at AGH, although the pre and post-op care is extended out in the community. It's led again by Masaki Tsukishita, Manri Kanwar, supported by myself, and second in command is Candace Lee. The heart transplantation program has been in place since the 80s with fantastic results. In the most recent outcomes, again publicly reported, the AGH program is the best 1 in 3 year transplant survival in Western Pennsylvania, and then the iteration before that, the best in the state and the region. Again, a fantastic team ensuring these outcomes, and a variety of awards and recognitions, Center of Excellence status with Blue Cross Blue Shield and Optum since 2015. Hypertrophic cardiomyopathy, another kind of really specialized, high quality program with both medical and surgical arm, is a cardiomyopathy that again can be highly mortal. Most patients are able to be temporized with medical treatments. The program is led again by Craig Alpert and Pietro Bayona, one of my surgical colleagues, and actively in pursuit of the HOCM Society's Center of Excellence, which we expect later this year. The program has really taken off since we recruited Pietro a couple of years ago, achieving best-in-class outcomes for these patients here in Western Pennsylvania. So we touched on structural heart disease a little bit when we're talking about the aortic and mitral valve, but again, the program's been in place since 2012 under my leadership with Dave Lasorda from Interventional Cardiology. Participated in just the vast majority of the most important clinical trials over that time period, and through multidisciplinary, multi-institutional collaboration, we now offer these services not just here in Pittsburgh, but in the south of town, the east at Jefferson and Forbes, as well as at St. Vincent's. Other aspects of the structural heart disease program include occlusion of the left atrial appendage, closing various communications either around valvular prostheses or between chambers of the heart, which are not ideal. This is under the leadership of Dave Lasorda, who's really a national leadership in these really creative kind of think outside the box approaches to really difficult clinical problems. Moving on to aortic disease, again, very much a multidisciplinary effort, from managing hypertension and lipids and cutting down on risk factors for aneurysmal disease to the most complex high-end surgical intervention from our cardiac and vascular surgery colleagues. The program here is surpassed by none. Just an example of a patient who had a prior aortic dissection repair, but presented back with a large aortic root aneurysm and a residual dissection, a large aortic arch aneurysm, taken care of by my colleague, Dr. Tsukishita, did a composite aortic root replacement with coronary reimplantation, one of which was implanted with a Cabral graft to minimize the risk for occlusion or torsion, a total arch replacement, and then a frozen elephant trunk where we, at the time of circulatory arrest, drop a stent graft in the descending thoracic aorta, into which a second stent graft can be placed if needed later down the line. Again, just the absolute highest complexity, highest quality care available. Really offer the complete gamut of aortic disease intervention, from purely percutaneous to open surgical, and of course, medical prevention. Quickly moving on to the thoracic surgery program. Again, just this week, the Benny Wexler, who leads the thoracic program, received STS 3-star recognition for the lung cancer program and for the lobectomy procedure. And again, the institute performs a wide breadth of procedures for the whole gamut of thoracic disease. Listed here, everything from benign to the most malignant conditions with phenomenal outcomes. We just recently extended, Dr. Wexler and his colleague, Dr. Fernando, both do over 90% of their cancer procedures minimally invasively. Interestingly, Dr. Wexler does mostly robotic. Dr. Fernando does mostly single port video assisted non-robotic procedures. Both are awesome. Both patients get phenomenal care, and we've extended this expertise up to the Erie market with Dr. Wexler maintaining a clinic and a surgical procedural presence in Erie for the last year or so. Again, the whole gamut of thoracic programs is offered for your benign and malignant thoracic pathology. Our vascular surgery program, again, second to none, led by Satish Maluk, take care of absolutely the whole range of vascular surgery diseases and pathologies. They really take pride in offering the whole spectrum of care, from sort of the most straightforward venous procedures to things that can only be taken care of in a quaternary care environment with 15 different teams contributing to the care. Outcomes are fantastic, and again, similar theme of participating and leading, the most important clinical trials that are driving, best-in-class care throughout our footprint in AHN. An offshoot, really important offshoot of the vascular surgery program is our wound care program. Again, this extends throughout the network, led by Elisa Taff, who's an internal medicine physician by training, but a surgeon at heart. She leads our wound program and leads it with a smile, and is a friend to all surgeons and patients who have a difficult wound to heal. She's and her whole team really work magic and can solve some problems that seem unsolvable at times. Again, have 9 locations throughout the system and are actively working on really standardizing the care processes and pathways throughout the network, which will only bring added value going forward. Cardiac rehabilitation is, I think, our final topic, and that's good because I'm 2 minutes over my estimated time. Cardiac rehabilitation, you may not think about it too much, but I prescribe it for every one of my surgical patients, for the simple reason that people who go to cardiac rehab after they've had a heart attack, stent placed, or surgery live longer than those who don't. We've got a phenomenal team, great technology in a wide variety of locations, providing just the best and most humanistic care to our patients, making sure that a technical success in the operating room or in the procedural suite becomes a holistic success, and that patients get back to where they started, or even better, to where they want to be after their cardiac condition has been definitively treated. We have rehab centers throughout the network with leadership shown here and pictured here, really a phenomenal group led by Srinivas Murali. I think with that, we have arrived at the last slide, and I'm out of breath because I was talking so much because you people didn't come up with any questions. So I think that there might be one more question here that that I'm going to read through quickly from Sherry Harmon. Thanks, Sherry, for the question. Oh, wow, this is awesome. So I work in clinical appeals team for AHN. I've seen a number of denials for acute CHF with TAVR. Not enough clinical treatment for sporting ECF and TAVR treatments. So I've got a long question from Sherry, which is a really good one, regarding sort of billing and coding the degree of how sick patients are at the front end. I think I'm going to take that one offline too, because beyond the scope for probably most of the audience, but a really, really good question. And Sherry, I will loop back to you when we're done with the formal talk. I think, with that, I was going to conclude. I apologize for the whirlwind nature of the hour. I did leave some time for questions, and if you have any, please pop them into the chat box. And then I just threw my cell number on there. Again, my name's Steve Bailey. I more than welcome a text or a phone call from anybody about really anything within the scope of the CVI, or even not the CVI. I take great pleasure in trying to get people to the right provider, and really, often feel bad for people who don't have any contact in the health system to try and get where they need to go. So really love trying to provide that link. With that, I will close and see if I think that's the only question. William or Megan, any other questions from the group?
No other questions. I think we're good.
None that I can see, Dr. Bailey. With that said, if we have nothing else, I just want to again thank everybody for joining today's webinar, and of course a special thanks to Dr. Bailey for presenting. And for more information on the Cardiovascular Institute and our providers, please visit our Find a Doctor website and search your desired provider or location, or reach out to Dr. Bailey as he stated earlier on. And lastly, you will all receive a brief survey at the conclusion of today's webinar. Please take a few minutes to complete this survey, as we value your feedback in making future improvements. Thank you all and have a great day.